Yes, you're audible. I can hear you.
Okay, thank you, Dr. Laigo. My name is Dr. Charles Zioki, a pediatric endocrinologist and a vetologist from Machakos Level 5 Hospital. Let me take this opportunity to welcome you for this webinar tonight. And this is part of a series of webinars on type 1 diabetes. And our topic of interest tonight is on insulin therapy in pediatrics and children with type 1 diabetes. As we are aware, insulin is the key to care of the child with diabetes. And we need to optimize the dosing and the appropriate regimes to ensure long-term survival and a good quality of life. And this country, there has been some concern about the continued use of mixed in the management of children with diabetes. And so our speaker tonight will be taking us through the various appropriate regimens which are intended to optimize the care of the child. We shall be receiving questions or other questions at the end of the session. So I'll be requesting each one of you to post your session on the Q&A wall. And at this point, it's my pleasure to introduce to you the speaker tonight. Our speaker is going to be Dr. Paul Laigo. He's a pediatrician, endocrinologist, and a lecturer at the University of Nairobi. And of note, is among the first pediatricians to specialize in pediatric endocrinology and diabetology. And is very passionate in the care of the child with diabetes. So it's my pleasure to welcome you, Dr. Laigo. You can take over from there. Thank you.
Thank you, Dr. Nzioki. So we are discussing insulin therapy in children. And as already said by Dr. Nzioki, is that insulin is the mainstay of therapy in type 1 diabetes. And is the one that we must get right for the survival of our children. So we'll go through this program. I promise you a short presentation and to give us time for discussion and sharing of the experiences that you have in your centers. So in the background, from as long as 1889, when symptoms of diabetes were connected to the pancreas, and looking at those chemicals, what was it in the pancreas that was that when it went missing, then there would be diabetes. And around 1910, it was found that there is a chemical in the pancreas that was missing. By 1921, we were doing experiments on pancreatic extracts. And these investigators looked at dogs without a pancreas. They removed the pancreas and then they fed them on the extracts, and they survived. And when they ran out of the extracts, the dogs died. After that, people then started trying to purify what is this in the pancreas, this chemical in the pancreas. And that's when we started injecting patients with insulin around 1922. By 1982, genetically engineered synthetic human insulin became commercially available. And to date, we are using either the human insulin or modified human insulin, which is genetically engineered. And this avoids then the reactions that were there initially for when we are using insulins from the dogs and the cows. So insulin, as we look at it here. So human insulin is what we are seeing at the top. And the modified human insulin is what we are seeing at the bottom. So on the bottom left, what you are seeing as part insulin. We'll go through this when we come to the regimens that we are using to treat patients. And you can see that the difference is the modification in terms of the proteins the protein chain that we have in the insulin. So if aspartate is replaced, as shown here, here's my cursor, then that becomes, that's what you're pulling into it aspartate because of the protein that is given there. And the change in glulisin is in two places, glycine there and lysine here. So glue for glycine and the lysine for these other protein, and that gives us the glulisin. Lispro is not the change of lysine in one position. For this, on the bottom right, you can see again just a modification of the protein chain of the insulin, and this changes the characteristics of the human insulin to suit the care that we want to give our patients. We will discuss the pharmacokinetics that arises from this in the slides to come. So what happens naturally when there is normal physiology functioning? How does the body react to the glucose load? And the glucose load here is from carbohydrates mainly and a bit of fat, which upon digestion gets into the blood system as blood sugar. And as you can see on top here, although the units is in milligrams per deciliter, you will see that when our blood sugar is flat, when you're sleeping, you have some insulin that is secreted. And if you look at this diagram, there is no time that you don't have insulin in the system. So we have some amount of insulin all the time in our system. During the times of meals, breakfast, lunch, and supper, then you see that the blood sugar tries to rise up, but that is matched by a rise in the insulin secreted by the pancreas. And this usually would match the amount of food that is taken. If you take a lot of carbohydrates, then more insulin is secreted, so that we have a balance. So important to note is that all the time we have some insulin, but then we have a huge dose of insulin secreted as a bolus to take care of the food that we take. And this is important when we come to trying to manage insulin, because we'll then try and fit into this system. What insulins are available for us, as we've seen, the rapid-acting insulin, Lispro, which in our market is called Humalog. Aspart in our market we call Novorapid, and glulisin, which is Apidra. And the insulin that is commonly known as regular or soluble insulin, that's our short-acting insulin, and it is in the market. In our market, either Humulin R or Atrapid. The intermediate insulin that we have is NPH. In our market, we have it as Humulin N or Insulatard. These are the trade names that are available locally in our market. And I'm putting this intentionally so that we don't confuse the trade names and the generic names. The long-acting insulin that we have in our market is Clagil, which the proprietor calls Lantus. We have Detamid, which is called Levemir in our market, and Decludec. Decludec is a long-acting form of Clagil. So these are the insulins that we have in the market. Now, there are few, and it will be good to remember them, because the patients that you see might be in any of these combinations. And if they come with Humulin N, then it's good to realize that this is NPH. Insulatard is NPH, so that you don't confuse the insulins. You get to know which or what a patient is taking when they come to us. What are the pharmacokinetics of these insulins? As we can see, the names. The names. Dr. am I clear? So as the names go, if you look at the rapid acting insulin, the three that we have in our market, you see that we have quite a rapid onset of action, and the time to reach the peak about 3 hours, and by about 4 to 6 hours, that group of insulins will not be in our system. Our regular insulin, the short-acting insulin, takes about 60 minutes at the onset and reaches the peak in about 3 hours and lasts about 8 to 10 hours. The NPH, that is the neutral protamine agonist, that's what NPH stands for. Then our intermediate acting insulin, and this one peaks in about 10 hours and is for most boys 12, but sometimes it may work up to 18 hours. And the longer acting insulins, peak of about onset about 2 to 4 hours, relatively flat with no peak, and they work up to 24 hours. Now, the idea of getting to understand the kinetics of these insulin types is so that when you're prescribing them for the patient, then in your mind you know that if you're giving a rapid acting insulin, then you need to inject it about 15-20 minutes before the meal. And you know that by about 4 hours, that insulin will be out of our system. If you're prescribing a short-acting insulin regular, then you need to prescribe about 30 minutes before the meal. And you see that it takes a longer time, duration of action, so that you realize that if you're giving these two insulins at breakfast, you see that the short-acting insulin will work longer than the breakfast that the patient took, while the rapid-acting insulin would match the meal. Now, the intermediate acting insulin, since it works for about 12 hours, for some people, they give it twice a day, but you could also give it once a day, depending on the combination that we are using it with. The long-acting insulins are usually given once a day, unless you're giving small doses for some very young children. Some of them require a twice daily injection, but usually it's once a day. So you understand this pharmacokinetics, and this helps you to picture what happens to the patient. Given differently, the same information is what we see here. So you can see aspart, lispro, and prolicin. Those are the black light. Sharp rise, but sharp fall also. You can see regular insulin, not very sharp, but it also takes time to fall, and your NPH. And as I say, I insist that this diagram is to help us understand these insulins when it comes to the treatment of patients. We've gone through that. So what regimens do we use when you're prescribing insulin for the patient? Remember, our aim is to mimic the natural selection as much as possible. Therefore, we do a basal and a bolus insulin. I think that's what you see on this diagram. But you look at this blue line, and that gives you the amount of insulin that you need as a basal insulin. This blue dotted line running down here. So you need some basal insulin all the time. But when you're taking your meal, you also need an insulin that covers that meal. Okay? And you can match it to the size of the meal as we're going to see. So the regimens that you're seeing here are two regimens that uses the regular insulin, that is the REG that you're seeing here, and the NPH. Ignore the lenter, we don't have lenter insulin in the market currently. On the diagram on the left, this is a patient who gets 2 shots every day of NPH, one in the morning, one in the evening. Then get regular insulin for the meals, breakfast, lunch, and supper. Now, when you look at this regimen, you look at this regular insulin, and you see that before it, when it falls down, you're already having lunch, and you're taking another dose. At the same time, you have your NPH peaking. So if you're going to give 3 shots of regular insulin, then your NPH might not be needed because you always have some insulin in the system. Our meals are usually about 6 hours. We take our meals 6 hours in the day. So in the 12 hours of the day, we have 3 meals. And if you're using regular insulin that works for 6 to 8 hours, you'll see that they'll overlap. And therefore, you may not need the NPH in the morning. Then you have the regimen then on the right, where you use the regular insulin for the meals in the daytime. And you have 1 injection of NPH that will then cover for the night. Now, these are usually this regimen is the most affordable because we have regular in most of our hospitals, especially public hospitals in this country. We have regular and NPH. And this regimen would work very well for most of our patients. That is, you do regular breakfast, lunch, dinner, then you give 1 shot of NPH to cover the patient for the night as a bolus. Now, of course, the misgivings of NPH is that it has a peak that's about 6 hours after injection. And that peak might give the patient nocturnal hypoglycemias. And you know, the hypoglycemias is what limits our strictness in care. We must always be aware that at that peak, about 6 hours after injection, NPH has a peak, and the risk is that it may give hypoglycemias. So when you start a patient on this, then you must monitor your blood sugar, especially about 6 hours after giving your NPH. If you're using the more later insulins, then you find that if you're using either glargine or detalin, this solid line will give you a fairly stable amount of insulin as a dosage. And this is given once a day. The risks of hypoglycemia is lower. So for the night, you are safe with this long-acting insulin. Then when you're giving meals, as for breakfast, lunch, dinner, then you must have then the rapid-acting insulin, which is either, for this case, we are given Blispro or Aspart. They're the 2 commonest we have in our country. And that will cover this. And as you say, these are the duration of action is about 3 to 4 hours. And that only covers the meal. And between those 2 meals, then you find that you don't have the 2 do not overlap. You remember on the diagram we saw before, you go back a bit, you will see that if you're using the regular insulin, the doses overlaps in terms of duration of action. While if you're using the live Lispro or Aspart, then they don't overlap. So you are safer in terms that you don't get hypoglycemias at the time when the 2 insulins overlap. Now, you have some small doses here that you may give, especially if the patient is taking snacks, and if those snacks are big enough to require insulin, then you can give a small dose. Now, this will be insulins calculated according to the size of the meal that the patient is taking, as we will see shortly. Now, those three regimens, that is this one of 3 regular doses and 2 NPH, this one of 3 regular doses and 1 shot of NPH, and this one of 1 long-acting, then several shots in the day of the rapid-acting insulin, are the common regimens that we use in this country. Those are the common regimens that we use, and they are the 3 that would best, if you remember how to use them. Those will be what we use. Now, a few of our patients have this diagram on the right here. Now, what you see here is that all the lines are the same, so all of them are using this point aspect. Now, what we see here is a continuous insulin infusion, or what we call insulin pump. If you're using an insulin pump, it gives you insulin continuously, and you set it. If you see this line coming in steps, that is the basal insulin. So you set the pump to give you a basal insulin. Daytime, usually you need a higher basal insulin. Nighttime, you need a lower basal insulin. You also instruct the pump whenever you are eating. You instruct the pump on the amount of insulin you're eating, and it will give you the bolus insulins as we see here. So this would be instructions that you give the pump at the time of the meal. If you're not eating, then the basal that is set would be running as you see in this diagram. Now, there are few patients in this country who are on the insulin pumps. This is mainly because of the cost restrictions. So those are the 4 regimens that we've gone through that you would give for our patients in this country. Let me repeat again, I hope I'm not boring you, that you can have regular insulin-free shots and 1 dose of NPH at night. That would fit most of our patients. Some of our patients, those who can afford, can take this regimen. They get 1 shot of the long-acting once a day, and then the shots of the rapid-acting during the time of meals. Those who can afford can go on the insulin pump. So let's look at this and see which one would fit our centers where we're working. So what's the dose of insulin? So we've seen the regimens. What's the dose of insulin? Now, I know DKA will be discussed in the upcoming lectures, but insulin in DKA is 0.05, 0.1 units per kilo per hour for children, and you start about 1 or 2 hours after fluid suspension. Once the DKA is resolved, then you switch the patient to subcutaneous insulin. If it's a patient who has been on insulin, then you may want to start them on the regimen that they were taking. Then you adjust before you discharge. If it's a newly diagnosed diabetic, and as Dr. Amala told us yesterday, most of our patients, 70–80%, come in DKA. And of course, when a patient comes in DKA, it's a sign. If most of our patients are coming in DKA, it's a sign that we are not educating our public enough that they should be able to pick. I'm not sure it's the public alone. Probably even ourselves, we need to pick those symptoms quite early so that we can get our patients before they go into DKA. But for newly diagnosed diabetic, after DKA, if that patient is pre-prepared, then we start at 0.05 units per kilo per day of insulin. If it is prepared, then it's 0.75 to 1 unit per kilo per day. And this is where you start. This is where you start. If you're using the rapid-acting insulin and the long-acting insulin combination, then 50% would be the rapid-acting insulin. If you're using regular insulin, as I said, they overlap, so you have some basal, then 70% would be regular insulin, and the long-acting would be 30%. Now, the rapid-acting or the regular is divided usually 3 times because of the 3 meals that you take in the day. So breakfast, lunch, dinner, so it's 3 times. So this is the dose. As you see, the regimen is either rapid-acting 3 times, the long-acting once a day, or regular insulin 3 times, and 1 NPH at night. And the division is 50% if it is rapid, or 70% if it is regular, and the remainder would then be the basal. So once you've started your patient on insulin, then you need to monitor. And what you're monitoring mainly is the blood sugar. And when they do blood sugar monitoring, in the hospital and at home. It is what you're trying to manage. So that you keep the blood sugar as near normal as possible without causing hypoglycemia. The frequency of the blood sugar test will depend on the availability of resources, how controlled the patient is, whether the patient has other illnesses. If a child has malaria or pneumonia, patient with diabetes, then you know you need to check the sugar more frequently because of the risk of hyperglycemia. But if the child has gastroenteritis, is not feeding well, has diarrhea, then you know that unless the fluid you're giving us dextrose, that patient is likely to get hypoglycemia. So then you increase the frequency of testing. So that minimum, if it is available, then we do pre-meal monitoring. So you do a blood sugar before breakfast, before lunch, and before dinner. And this helps you in terms of not just knowing the control, but also deciding how much insulin to give, as you're going to see shortly. For that patient who is not controlled, and you want to see whether the insulin you're giving, this short-acting insulin regular, or this rapid-acting insulin, is equal to the meal, then you also do a blood sugar after the meal. Now, if you're using the rapid-acting insulin, then you want to check your blood sugar 2 to 3 hours after the injection, because that's the time the insulin reaches its peak. While if you're using the regular insulin, then you want to check the post-meal blood sugar 3 to 4 hours after the injection, because that's the time the insulin peaks. So the timing of the post-meal depends on the insulin you're using. If it is a rapid-acting, about 2 to 3 hours. If it is regular insulin, about 3 to 4 hours after the meal. For the newly diagnosed patients, check your sugars at bedtime, check your blood sugar at 3 a.m. As I said, if you're using like NPH as your vessel, 6 hours after the injection, that insulin peaks, and that's a risk for hypoglycemia for that patient. If you're starting a patient with insulin at first, newly diagnosed, and you want to see how much of your long-acting insulin you're using, it's good to check sugars at night so that we avoid the nocturnal hypoglycemia. Now, that regimen is for patients who are checking their blood sugar using the glucometer. Some patients may be using the continuous glucose monitor. A continuous glucose monitor is a gadget that you'll see the picture shortly, that we put on the arm of the patient. It checks the blood sugar every 5 minutes or so. And for the newer machines, will actually alert whether the blood sugar is going too low or is going too high. It's a very good system of monitoring the blood sugar, especially for those patients who are struggling to control, which you can use continuous glucose monitor for 2 weeks, 1 month, or for patients just that you can't understand. And most of our adolescents, sometimes you really don't understand what they do with their blood sugar. A continuous glucose monitor would help you in that matter. If a patient is getting nocturnal hypoglycemia for reasons that you don't know, a continuous glucose monitor will help you to give you a picture of exactly what happens at what time this hypoglycemia is happening. There are also patients who come to you with very nice readings, very good looking, the book looking very nice. When you want to check whether they're actually controlled or not, like using a HbA1c, then you discover that those readings don't match. For those patients, a continuous glucose monitor would help. Now, for all patients, they need to keep a chart of their blood sugars, the amount of insulin they are taking, and the food they take. And for food, type and amount. Now, in amount here, it's whatever measurements they're able to, whether they use cups, whether they use serving spoons, whatever measurement they have, that's what they would use to say this is the amount of food I've taken. When you relate blood sugar, insulin, and the food taken, then you can monitor the patient, so you can adjust your insulin dosages better. So how then do you make use of this information? You've done your blood sugars these many times. How then do you interpret one results you have, and therefore what insulin changes are you going to make? So the fasting blood sugar, that is when they wake up in the morning before they take any meal, and they do blood sugar. What information do you get from that blood sugar? So the interpretation is that that blood sugar tells you about the long-acting insulin, the basal insulin. So if you're giving your basal insulin once a day, then you check the adequacy of that insulin with the fasting blood sugar. If you're giving NPH at night only, then that's the one you're checking in the morning with the fasting blood sugar. Is that dose adequate or not? What changes do you have to do? Do you need to increase the dose? If the patient is getting hyperglycemia, do you need to reduce the dose if the patient is getting low blood sugar? So you use that to monitor. If you check your blood sugar after breakfast, and you sit after breakfast, either 2 to 3 hours if you're using rapid acting, or 3 to 4 hours if you're using regular insulin. So that blood sugar that you're checking will tell you about the adequacy of the morning short-acting insulin you gave or the morning rapid-acting insulin that you gave. If you're checking blood sugar at lunch, then it will be telling you about, that is, if you're checking the blood sugar after lunch, it's telling you about the dose of sugar you gave at lunchtime. After supper, it's telling you the dose of insulin you gave after supper. Then there are these two, pre-lunch and pre-supper. Pre-lunch insulin, pre-lunch blood sugar will tell you one about the insulin you gave in the morning, the effect of the snack, and the effect of the long-acting insulin. Remember, your meal for breakfast will be over in about 3 hours. So you have another 2-3 hours where there is no food, unless the patient takes a snack. So it will assess those three: dose in the morning, the effect of the snack, and the long-acting insulin. So that if the blood sugar is high before lunch, then you're looking at what snack the patient take. That usually is the one that tends to raise the blood sugar at that time. And if there was no snack, or the snack is not large, then you're looking at your dose of long-acting insulin and the dose of what you give in the morning, especially if in the morning you're giving regular insulin. Pre-supper will be the same. Now, all these levels will be affected by snacks and exercise. Exercise usually makes our bodies more sensitive to insulin. And the day that the patient has a lot of exercise is the day that you expect the sugars to be low. And the risk of hypoglycemia then goes up. So you must assess always that how much exercise was done on this day, what kind of exercise, and for how long. Strenuous exercises will always may make the patient get hypoglycemia. Caution, of course, is given, but if the patient avoids an injection of insulin or gives too little insulin and too much food, blood sugars above 15, then exercise may not be advised, because then the risk of going into decay will be higher. But for a patient who has enough insulin, is taking the other, then exercise will make them actually more sensitive to insulin and will make it hypoglycemia. Now, this is a repeat that you need the records of the insulin, the food, activity, those things, so that when you are analyzing your blood sugars and the doses of insulin at a particular time, then you need to know how much insulin was given, what food was taken, and how much activity was done. Adjustments of insulins will depend on the blood sugar. It's going high or going low, usually 10 to 20%. If you want to either raise or lower your insulin, and see what the response. Now, These are other important factors to consider. So the insulin to carbohydrate ratio. These patients who are using usually rapid-acting insulin or on continuous insulin infusion on insulin pumps. But you can also do it if you're doing intermittent insulin. Now, the insulin carbohydrate ratio is useful when you want to do carbohydrate counting. And this is just the amount of insulin that will maintain a normal blood sugar when a particular amount of carbohydrate is taken. For most patients, it's either 1 unit of insulin to 10 grams of carbohydrate, or 1 unit of insulin to 15 grams of carbohydrate. That usually would be the starting point. But then as you continue taking care of the patient, then you keep assessing. And if this patient takes this amount of carbohydrate and I've given this number of units of insulin, what does the post-meal blood sugar look like? It's something that you calculate every time. And it may change. You may find that your patient in the morning, probably because of raised counter-inflammatory hormones, cortisol, you may find that the sensitivity in the morning, you need more insulin for a particular amount of carbohydrates than what you would need during supper time. So you may change in the course of the day. Then there is a correction factor, or insulin sensitivity. Now, this one you calculate in this manner. If you're using a rapid-acting insulin, there's a least pro aspart, then you divide 100 by the total daily dose. So the patient is taking 10 units in the day of rapid-acting insulin, then the correction factor will be 100 divided by 10. Now, the number you get there is the amount of blood sugar drop that 1 unit of insulin would cause. So if you give 1 unit of rapid-acting insulin to the patient I've just told you about, then you expect the blood sugar to fall by 10. Now, if you're using regular insulin, then you use it to 10. Because rapid-acting insulin drops the blood sugar more than regular insulin unit by unit. Now, this, as I say, is for those patients who really want to be very keen in the amount of food they take, so that you're not taking the same amount of food all the time. If the amount of food is varying, then every dose of insulin, you consider these two. Consider the insulin carbohydrate ratio. If this patient is taking 60 grams of carbohydrate and the sensitivity is 1 to 10, you need 6 units. And if the blood sugar is more than 10, usually we correct blood sugar that is more than 10, then you calculate the correction factor, then you add those two to make a dose of insulin. So that's more strict control of the blood sugar. Okay, then we said fasting blood sugar. If you have hyperglycemia in the morning, before you change your dose of the basal insulin, you need to look at these two effects: the dawn phenomenon and the Somogy effect. Now, the dawn phenomenon is where you find that your blood sugar is normal at night, but it tends to rise in the morning. Usually just before waking up, you will see that the blood sugar is rising and you get hyperglycemia the time you're checking. If that is what is causing the hyperglycemia, then your response will be to increase the amount of the basal insulin. Now, in Somogy effect, it's the body's response to nocturnal hypoglycemia. The blood sugar falls down at night, and in the morning, due to the body's response to low blood sugar, then you find a hyperglycemia. Your response to Somogy effect would be to reduce the dose of the long-acting insulin or the basal insulin. So when you see high blood sugar in the morning, you must do this nocturnal, you must do blood sugars at night. so that you know whether you're dealing with a Down phenomenon or some more effect. Because if it is Down, then you increase the amount of insulin, the basal insulin. If it is a more effect, you reduce the amount of insulin. So morning hyperglycemia, you must be sure which of these two you're dealing with. So that would be the dose. So we've gone through the regimens of insulin. We've said we do either rapid acting or regular insulin, 3 doses in the day, and a basal insulin, whether NPH or the long-acting insulin. We've said that your starting dose, if it is 50 parties, 0.5 to 0.7 units per kilo per day. The patient in puberty, 0.75 to 1 unit per kilo per day. Divided so that if you're using regular insulin, non-regular would be 70%, and the basal would be 30%. The rapid acting insulin, then it's 50-50. 50% will be rapid acting and 50% will be basal insulin. And we've gone through your blood sugar monitoring and which insulin to adjust, depending on which blood sugar it's either high or low, as we've seen on this one. We've said if it is morning hyperglycemia, be sure if it is Down phenomenon, increase the dose of the basal insulin. If it is a more effect, reduce the dose of the basal insulin. Now, injection technique. This is one common cause of uncontrolled diabetes. So I think we all know that insulin is injected. We don't have any other form of insulin. If you look at the top left, how do you hold the skin? You want to put insulin in the subcutaneous fat. That subcutaneous fat is where we want to deposit the insulin. You need the injection to go through the skin into the fat, but we don't want insulin in the muscle. Now, there are two things. If you put in the muscle, it will be absorbed more rapidly, and therefore you may risk hypoglycemia. You're giving a short or rapid acting insulin. If you're giving a long acting insulin, it may not last the 24 hours that you wanted it to last, or the 12 hours it is NPH. So when you're holding the skin, don't pull up the muscle. Don't pull up the muscle. Just the skin and the fat. Don't pull up the muscle. So that's the correct pinch. Which areas do we inject? Abdomen, except the navel. Avoid the bones. Then that is the ribs and the iliac crest. Then you can divide because you need to rotate this side. So you must rotate your side. If you inject the same place all the time, you land in trouble. With the insulin, either lipohypertrophy or lipohypertrophy. So you rotate the sides, and you can, this is one way of rotating. You're given here those numbers 1, 2, 3, 4. Now I did this, and then next time that side, this side. And if you do that, then the injection site will remain good. On the lateral side of the thighs, again, you can number them so that you rotate the sides. You can also do the upper arms. Again, this is the outer side of the upper arm. And not in the deltoid and not below the elbow. You rotate the same way, like shown here. So those are the injection sites. This is the correct pinch. Now, do we inject at 90 degrees, at 45 degrees, or what angle? Now, that depends on the size of the needle you have. What we want is to have that insulin in the fat, not on the skin, not in the muscle. We need in the fat. So if you're using the small, short needles, 4 to 5 millimeters, the best would be to go 90 degrees. And for the older ones, you may not even need to pinch the skin. It will just go under the skin. If you're using the longer one, 6 to 8 millimeters, then you must pinch the skin. And you can still do 90 degrees. You're using the long needles, 10 to 12 millimeter needles, very long ones, then you must go at an angle. Because if you go direct, to shown here, you will go into the muscle. So you must do at an angle. So whether you're doing 90 degrees, 45 degrees, will depend on the size of the needle you're using and the thickness of the skin of the patient. You find that the young ones, We have less the fat, therefore even with the small needles you may need to pinch. The long needles you most likely always have to go at an angle. So whether you go 90 degrees, whether you go at an angle will depend on the size of the needle you have and the patient's skin. Always make sure that you advise the patient depending on the skin and the size of the needle, so that you tell them for this particular needle for you, do 90 degrees. Or for this needle for you, do 45. So that will depend on the needle size and the skin thickness of the patient. So it has to be individualized for your patient, so that you see what's happening on your patient. How do we deliver insulin? We said you can use the traditional syringe and the needle. Now, the only thing you need to know is that these are volume. They are graduated in volumes. So the units you see here depends on the volume. Our insulin is usually 100 units per ml, and you'll see that written on this needle as U100. So make sure that that label written here, U100, is the same as the one for the insulin that you're aspirating. This one here is an insulin pen. Most of our insulins currently are coming in pens. And when they come in pens, it's easy to also it's a gadget here that you dial. You just dial the unit that you want and inject. The needle is fixed here. The same way the needle is fixed on that syringe. Now, this value we are seeing here has three things. So this one on this side is a subcutaneous cannula, and this one here is the insulin pump. So this gadget, this insulin pump, will give insulin continuously. As you said, you set what you need. If you want a basal insulin, you set how much basal insulin. And that's what it will give you continuously. It's by the time you set. You can vary, of course, the basal insulin between day and night so that you have more in the day, less at night. And once you set that, that's what the pump will do. When you're going to eat a meal, then you instruct the pump to give you a bolus for the food. And that insulin is pumped through this cannula, through this tube, into the cannula that is under the skin. And that's how your insulin is given. Those are the three main delivery methods that we have locally in the country. Now, this patient also has another gadget here. This gadget here is what we call a continuous glucose monitor. Again, it checks the blood sugar. There's a tiny cannula that is put under the skin. Most of the time it's in the arm. And once you put it in the tummy. So this checks your blood sugar almost every 5 minutes. When you can get a reader, or the modern ones can send you the readings on an app, so you can see on phone. So for those who have children in school, this one will be checking, sending the things on your app, and you can be looking at the blood sugars from wherever you are in this world, as long as you have an internet connection to your phone. Now, a little technology that is coming up, actually picking up in some countries now, is that this continuous glucose monitor will check the blood sugar and send that message to the pump. And that communication the pump will then decide how much insulin to give, depending on the blood sugar that they are recording here. Blood sugar is going high, the pump will give a little bit more insulin. If the patient is going into hypo, the pump can actually shut and stop giving insulin. And that is called an external pancreas, kind of artificial pancreas, that you have a sensor that senses the blood sugar and communicates to the pump, and the pump decides then how much insulin to give, or even to shut down completely if the patient is getting hypoglycemia. This technology is, we have continuous glucose monitors locally, we have pumps locally, and the artificial pancreas is yet to be established locally. Finally, how do we store insulin? Our insulin is sensitive to shaking. If you don't shake, sensitive to temperature. So you must keep it cool. 5 to 8 degrees Celsius will be best. And you must avoid light. Direct sunlight also affects the potency of insulin. So those with a fridge, you can put it in a fridge. Don't put it on the window. Without a fridge, then you can use traditional methods that have been used successfully. In the Annals of Medicine 2022, they found out this gadget here, these pots. So you have the pots, a big one, then you have a smaller one. In between those two pots, you put sand, and you put water in that sand. As the water evaporates, it causes a cooling effect, and it actually cools. The insulin itself should not be in contact with water. So be kept in a dry, as you can see. This insulin here is kept in a small bag that is tied. So it should remain dry. But as long as it's dry, doesn't come in contact, the water will be on this with the sand. That will cool. Same with this one. Those will keep your insulin cool enough for use. For those using pens, the pen that they're using will be steady at room temperature for up to 1 month. You don't have to keep it in a fridge or keep it in a pot if you're using the pen. Once you put on the fridge, it's the extra one that they must always have for emergencies. Thank you. I think I'll stop at that point and allow us to discuss.
Thanks a lot, Dr. Laigong. It's a very enlightening session. And we are going to go to the questions and do further discussion through the questions from the audience. So we are going to start with a question from somebody who's an anonymous attendee. And the issue of question is that can NPH be used as a long-acting insulin in facilities where we don't have landers? In most public facilities, children with diabetes type 1 are on mixed insulin. I would want to transition a patient from mixed to insulin. And I'm going to request Dr. Priska Molo to take over this question. Priska. Dr. Priska. Okay, Dr. Laigong, I think you had alluded to this in your session. I think you can take over.
Yeah, I think if you look at the slide I'm posting now, the diagram on the right, yes, we can use NPH as a basal insulin. It is an intermediate acting insulin. It's not a long acting insulin, but it can be used as a basal insulin, as but the diagram on the bottom right, where you have 3 shots of regular insulin and 1 dose of NPH for the night. So it can be used. The next question was insulatard with rapid acting insulin.
Yeah, NPH and quick rapid acting insulin.
Yes, you can use rapid acting insulin with NPH, but in that case, then you'll need 2 doses of NPH, 1 in the morning, 1 in the evening, because the rapid acting insulin does not overlap. As you can see on this diagram on the left, the regular insulin overlaps, and therefore that can give you a best, so you can avoid the daytime NPH and only do a nighttime NPH. If you're using the rapid acting insulins, those ones don't overlap, and therefore you need to give 2 doses of NPH, 1 in the morning and 1 in the evening.
Okay, thank you, Doctor. The second part of the same question is how do we move from mixed to NPH?
So mixed study, most of the mixed study we have is 70-30. That is 70% of NPH and 30% of regular insulin. You just divide those two, give the only evening dose of NPH and the rest of the regular, give in the day. You can use the same total amount of insulin that the patient takes in the day. Just divide so that you have the 3 doses of regular in the day and 1 dose of NPH at night. And as you said, you will switch so that the ratio then becomes that the regular will take the 70% and the 30% NPH will be the 1 dose you give at night. So you can switch from mixed to NPH and regular. And you should actually switch all your patients. Thank you.
Okay, thanks, Dr. Aigong. The next question from George Fernandez, let me just read it. How can we rally for increased access for Libra sensors for better blood glucose monitoring? It's what's better for children, but cost is prohibitive. Then this is a question which is trying to see how we can lobby for access to the sensors, to the monitors. What's your comment, Dr. Aigong? Any experience with these sensors?
Yes, we have patients mainly in private practice that are on sensors, and they work very well. The ones on the public that we have in Kenyatta have used sensors, some for short periods, like 2 weeks, 1 month, just to get to understand what's happening, then they go back to what they were using before. As Dr. Fernandez says, 14K every 2 weeks is expensive, and they've gone up with the shilling going down. They're now more than 14K every 2 weeks. Now, the lobbying, I think worldwide lobbying is best done through the patient support groups and for children, the parent support groups. Those are already in place. As we get more and more knowledge on them, we continue pushing for this. And that's why you're exposing them, even in the public sector, to how these sensors work and the benefit and the amount of information you get, the value of information you get. I think you can add, you're also in the public sector, what can be done?
Okay. I think I'll take out the next question from anonymous attendee, and his question or question is that it's unfortunate that a huge number of newly diagnosed type 1 diabetes are unable to afford glucometers. What can be done to assist these children? Some of the donation for these glucometers that were initially there ran out. I think this is a challenge for most of our diabetic children. And I think the bigger challenge is not the glucometers, but access to the strips. And we have a lot of partners now who are trying to assist, especially in most of the centers. We have CDIC, which is providing the strips and the glucometers. We also have some centers under the World Diabetic Federation. And we have the Pen Plus project coming in for Western Kenya and some parts of Eastern Kenya. So I think what we need to do is to try and get in touch with these bodies and see how they can assist the children in those areas which are who are unable to access these gadgets and the strips to assess them. I don't know, Dr. Paul, anything else?
Those who are close to KMH can come. We have some currently at KMH. So those patients who are close to KMH, they could come. The program at KMH is Life for a Child, and they are willing to expand. I think we just need to network and see how to get other centers benefiting too. But currently we have some. Those who are near KMH could come.
Okay, thank you. I think for us, even those ones around Machakos, we have some glucometers from CDIC. We would be happy to assist and help you from this region who doesn't have a glucometer. The strips are there. There are several questions about the CPD issue, and I think Dr. Priska.
I don't know why Priska is. No, it's best to deal with CPD for people who can be identified, like Derek Bessa and like Anonymous. Please, it's good to put your name and see. For the doctors, it will be posted directly to the board.
So the next question is, how do you match food taken with insulin dose? I think Dr. Paul, you can recover about the insulin carbohydrate ratio. I think that's what the anonymous attendee is asking. How do you match the two?
So the matching should be patient specific. As I said, for a start, the insulin to carbohydrate ratio is usually 1 to 10 or 1 to 15, the younger ones. That is 15 grams of carbohydrates to 1 unit of insulin. And simply that's how to match. Once you've started, then you assess your patient and see whether you need to change that ratio. And as I said, you may change that ratio so that in the morning you have a different ratio, different in the day, different at night. But it will depend on what you find once you've started. But start with 15 grams, see how the patient behaves, and then adjust accordingly. That's how to match food to insulin.
Okay, thank you, Dr. The next question is a photo of glucose monitor. I think we have seen several photos in the presentation. I think you are going to pass that one. And let me see what other questions are there. So somebody wants a recap of the dawn and the munch effect.
Yeah,
I think
so
yes, Doc.
I said these two, the causes of fasting hyperglycemia in the morning. And the dawn phenomenon is where the blood sugar is okay at night, but in the morning rises up. Usually just as the patient wakes up. And this is usually because of the cortisol in the morning. So Moji effect, on the other hand, is a patient who gets hypoglycemia at night. So low blood sugar at night, then in the morning, the blood sugar goes up. I said it's very important to determine which of these two is the one causing your high blood sugar in the morning. Because if it is dawn phenomenon, then you increase the amount of insulin, the basal insulin that you're giving. If it is a Moji effect, you reduce the amount of basal insulin you're giving. The only way to differentiate these two is to check your blood sugars at night, and that will sort you out.
So what's the appropriate time at night to check the sugar?
About 3 a.m.
3 a.m. So the next question is how to calculate correction factor in a patient of mixed diet. I think I'll take up this one, that you don't use mixed diet for correction. Your patient has to be, you use your soluble to correct NI sugars. And the correction factor is the same if you are using regular insulin citrate divided by the total daily insulin dose, but it has to be soluble insulin. So if you have to correct, your child must have some soluble insulin available for that purpose of correcting the high sugars. The next question is, what are the early signs and symptoms of early diabetes mellitus diagnosis? I think we went through the diagnostic criteria of diabetes yesterday, and I think we are going to pass that question.
Jackie, probably somebody missed the lesson yesterday.
You want to go through it, Doc?
I think simply is a patient who is taking a lot of water and passing a lot of urine, a patient who could be losing weight despite probably increased appetite. And if they're going into DKA, they have abdominal pain, vomiting, and Kussmaul breathing. And I think the early sign is taking too much water, passing too much urine. But that should be simple. Once you see that, check a blood sugar. So,
Yeah, okay, thank you. I think the question of the correction factor and carbohydrate counting still keeps coming. And somebody is asking for a recap on the correction factor and carbohydrate counting. Yes, Doc?
I think we've just recapped that on, I think.
Yeah, recap on that. So the next question is on the DKA guidelines. And what I would say is that the DKA session is coming. I think we can keep this question on hold until we do the DKA series. Repeat the dosage of rapid and long-acting insulin for initiation of treatment. Dr. Laigom?
For newly diagnosed patients, if this the total dose should be either 0.5 to 0.75 units per kilo per day. For those in puberty, 0.75 to 1 unit per kilo per day. If you're using rapid acting, we say 50% should be rapid acting and the 50% will be long acting. Once you start, you monitor the patient and adjust accordingly.
Okay, thank you, Dr. So I think the next question is about insulin factor calculation. I think it has been said that you use a factor of 3 divided by total daily dose, or 100 if you are using the rapid acting analogs. For human insulin, it's 3 divided by the total daily dose. Then what's the difference between NPH and the mixed stat? That's from one of the attendees.
Yeah. NPH is an intermediate acting insulin. Mixed stat is a mixture of NPH and regular insulin. So mixed stat has both NPH and regular insulin. NPH is alone, intermediate acting insulin.
And why are we not emphasizing the use of premixed insulin in pediatrics? That's the next question. We are avoiding the use of premixed insulin in pediatrics.
Premixed insulins have been left for type 2 diabetics. We don't use them for type 1s now. So everybody needs to move out of that.
Okay.
Control is not good, and risks of hypoglycemia is very high. So everybody should move away from premixed insulins for type 1 diabetics.
Yeah, I think the next question is a follow-up on that. Somebody's asking, how do you switch from rapid insulin and NPH to mixed stat? So if your child is on insulin, NPH and rapid insulin, then you don't need to switch to mixed stat. Mixed stat is not appropriate for children. How can you advise a patient with hyperglycemia on exercise? I think that one was touched, that if the sugars are above 15, then you need to avoid exercise because you can worsen the glucose levels and tip the child into hyperglycemia. So
sorry, I went off a bit. Repeat.
So the question is exercise and the modification we would make in dosing and timing for someone who is highly physically active.
there's a session on special situations, including exercise. That one is coming.
The next question from Emmanuel is what's the dose of mixture you can give per day? And can you give mixture dose in the morning and evening, and in between before lunch you give regular insulin if sugar is not controlled? I think we have answered that question, that we need to avoid the use of mixture in these children. It's not going to give us good control. We put all the children on NPH or landers and then regular or rapid acting insulins. Can we give oral medication in pediatric diabetes?
I think that's a broad question. If you are thinking of pediatric diabetes, that is not just type 1. If you're thinking type 1 diabetes, the answer is no. But pediatric diabetes, some patients have MODY, others have neonatal diabetes. There are some that may use oral hypoglycemics. But for type 1 diabetics, the answer is no.
Okay, thank you, Dr. And this is an important question. We have seen some patients who are type 1 being put on oral hypoglycemics. And the issue is that the mechanism of diabetes in type 1 is basically absence of insulin, and oral hypoglycemics are supposed to improve the activity or improve the production of insulin in the patient with some activity of insulin. So in this case, patients who have no insulin, then the oral hypoglycemics have no value. So it's something which is happening. I think a good number of patients being put on oral hypoglycemics, but let's say try and avoid and put all the children on insulin. Then somebody wants a recap on the types of insulin.
Okay, I cannot project my slides, but we see there are four types or 4 classes of insulin. There is the short-acting, the rapid-acting insulins, and we gave examples of Lispro and Aspart. There is a short-acting insulin, which is a regular or soluble insulin that is common in our hospitals. We have intermediate-acting insulin, which is NPH, neutral protamine hagedon. And this is also available in most of our hospitals. And then we have long-acting insulin. These ones we gave examples of Glargine and Detamine. Again, those are the 2 that are commonest available in our market. Those are the types of insulin. There are 4 classes and examples of each.
Okay, thank you. The next question from anonymous attendee is about hypoglycemia. I think we have a session on hypoglycemia in the course of the series. So we'll, with all these questions, until we do the hypoglycemia session. And then there's somebody who is asking for a recap of rate on regular insulin alone without long intermediate, without long or intermediate acting. And that some facility insist on purchasing mixed and nothing else. I think when the slides we went through, there was basically you have to mix both intermediate and long-acting and regular short-acting insulin. You cannot be on the regular insulin alone. And the issue of mixed is a big challenge. I think we know what's right now. We can lobby the pharmacists and people in the account to ensure that they have the right insulin for the children in our areas. So the next question is pre-mixed the same as mixed? Yes, mixed is a pre-mixed insulin, but there are also other pre-mixed insulin. So a pre-mixed insulin is one whereby your combination of either short-acting or rapid-acting and a long-acting or intermediate-acting insulin. Yeah, but they are not basically the same, but mixed is a form of pre-mixed insulin. Availability of long-acting landers in public hospitals and projection on how soon can be available in order for us to adopt a recommendation of combining Beso with the meal soluble. I think this is a question which keeps coming up in most of the public hospitals that we have inadequate or we don't have the landers, but KEMSA has been stocking, although we have been also having a lot of stockouts. So I think the same thing we said about the rest, that we need to start lobbying, we need to start demanding what's right. And then KEMSA through the count pharmacies and the count health system would be able to avail these landers. One of the reasons that unless we create demand, then it's not going to be availed. And this reminds me, the other day I was having a talk with somebody that he went to a county and found a lot of landers which was expiring because it's not being used. So it's for us to create the demand and make use of it. Otherwise, we end up like in that count whereby they have the landers, but they are still giving the mixed. So this one is a personal question. My son is on overrapid 3 times a day and the landers at night. With the frequency of doing the injection stop at some time, or will he continue getting the 4 injection daily? Dr. Paul.
I think, please repeat the question. You said the sun is in?
It's on novorapid 3 times a day and landers at night. With the frequency of doing the injection stop at some time, or will he continue getting the 4 injections daily?
I think that question is best answered by the person following up the patient. Or if you need contacts of one of us, probably get a contact and then we deal with it one-on-one.
Okay. Thank you. With the increasing lifestyle issues among children like obesity, at what age among children can you diagnose type 2 diabetes?
Type 2 diabetes can be diagnosed anytime. I think we don't have it very common among our children in this part of the world. But in the Western world, I think as young as 9, 10 years have been found to have type 2 diabetes. Obesity being the major driver of that.
Okay, thank you. Then from an anonymous attendee, why do sometimes a person using insulin and observing diet get a fasting blood sugar above 20?
That sounds like an adolescent. Those are usually adolescent issues.
Basically, the dawn phenomenon through too many counter-regulator hormones in the morning. I think we are through with the questions. Unless from the panel members where there is a comment, Dr. Priska. Another endocrinologist in the panel? Yes.
Good evening. Sorry, I don't have a comment, but I can see there's one question. I'm not sure if this has been addressed. Should pregnant diabetics be on insulin, or is there room for oral hypoglycemic agents? Dr. Legong.
Okay. I think I've missed that one.
I don't want to wade into OBGY. You want to try, Priska?
No, I don't. I think Dr. Fernandez is in the group. I don't know if you can make a panelist to make a comment. She's an OBGY, or if there's any other OBGY in the group, maybe you could raise your hand and we allow you to just respond to that. And as we wait for that, someone was asking to be helped with carbohydrate ratio calculation formula. So that will be addressed on the session on nutrition. So just hold on to that question and then you'll have the answer to that. Frederick, I can see Frederick Sawe is here. I'm not sure if he's an OBGYN. Let's see if we can add him to the panel. Okay, he seems to have dropped off. Okay, so I think I do not have any other comment in addition to what has been discussed. Just to answer the questions on CPD points, for the medical doctors, the CPD points will be automatically uploaded onto your ICPD portal. And then for the other cadres, an email will be sent to you with regards to the same. And for those asking for the presentations, this presentation will be uploaded onto the KNH Research YouTube page in the coming days. So you'll be able to access it from there. Thank you. Back to you, Dr. Nzioki.
Okay, thank you, Priska. Yes, Dr. Igo.
I see Dr. Fernandez has answered one of the questions. He's saying the pregnancy one can take metformin safely.
Okay. Okay, thank you. Let me take this opportunity to thank each one of you for attending to this session. Great to thank Dr. Igom for the wonderful presentation. I think, as Dr. Priska said, the CPDs will be forwarded to the various professional bodies. And we have come to the end of this session tonight. Thank you.
Thank you, everyone.
Bye.